to everyone. It really is an honour to be with you today at this important symposium on mobilising and disseminating knowledge in local authorities. As a councillor, my work is deeply rooted in the lives of local people. Every day, we are asked to make decisions that shape the future of our communities. This includes decisions about housing, health, education, and safety. And at the heart of those decisions lies one essential ingredient. That's knowledge. Knowledge mobilisation is about bringing these strands together. It means making research accessible, relevant, and practical. It means ensuring that research findings don't sit on a shelf, but are put into action. We know that communities face complex challenges, whether it's tackling child poverty, addressing health inequalities, or responding to the climate emergency. The answers really come from one place. The answers rarely come from one place. They come from research, from frontline workers, and from our communities themselves. So let me share a few examples from my own journey. In public health, research has helped us to understand how to support our residents to improve their mental health. We championed a 6-park 3-day walking challenge in June during Men's Mental Health Week. In the play service, we've carried out a play sufficiency assessment to understand the value of play for children and young people and how it affects their health and well-being, their satisfaction, their development and their learning. That evidence will drive investment in children's lived experiences and overall play satisfaction. And in climate resilience, we have worked with academics and residents to understand how air quality affects our most vulnerable communities. That knowledge will help us shape emergency planning and community awareness campaigns. These are just 3 examples, but they illustrate a vital truth that research can be put into practice to support decision-making for change based on evidence of what works. So, everyone, the theme of this symposium, knowledge, mobilisation and dissemination, is not just about information, it's about people and communities. As a counsellor, I may not always speak the language of academia, but I do speak the language of community. And if we, researchers, practitioners, policymakers and residents can work together, we can make sure that knowledge doesn't just exist, but changes lives. Thank you for listening.
Thank you, Councillor Taylor. That was really powerful. I'll definitely remember that quote, I speak the language of community. I really like that.
Thank you.
Has Frances joined us?
Yes, I have.
Oh, great. We're running just a little bit ahead of time, but I'll hand over to Dr. Frances Hoy now for her speech.
Okay, thanks very much indeed. So many people here won't know me. I'm the Interim Director of Public Health here at Sandwell, here for a year, and it's my role just now to be part of the sort of welcoming group, along with my Cabinet Member, Councillor Taylor, to open the event, welcome you to it, and to set the scene. And I was just going to reflect a little bit on evidence-based practice. So it feels to me that we are creating a social movement here, and it requires a change in how we all work. And I think there is something about understanding what evidence-based decision making is, which requires a really shared narrative from everybody across the system. And arguably one of our problems have been that lots of people make small contributions to this agenda, but don't develop that shared narrative as much as they might. So welcome to a day today, which is about creating that shared movement and shared narrative. So I was going to just reflect a bit on evidence-based practice from the health situation. Experience that I've got from working in the NHS for many years, and also I teach NHS professionals, post-qualifying fellowship GPs, and also master's level nurses, advanced clinical practitioners. So I've done a lot of thinking in the last sort of 5 or 6 years, as well as working in practice, on how we can go further and faster in terms of introducing evidence-based decision making to areas other than health. So today is really about doing that, doing the further and faster. So thank you for signing up to it, and thank you for being here. So when I look back and think about evidence-based practice in the NHS, I think about that leading change piece, and that saying now is the time in local government to lead this change. So in local government, we need an actual shift. We need a shift to understanding what works and making that happen. And when we think about how to bring about change, we often think about Cotter and his 8-step approach, which in general does work pretty well. It's a management approach, very kind of well worn. But the 8 steps approach starts with that first step 1, to create a sense of urgency. And I think we absolutely have that at the moment in all the public sectors, really, but particularly in local government. So we've got this business about our rising demand on our services. We've got an ageing population. We've got a changing population as populations shift globally. We've got rising inequalities that everybody's committed to changing but is unable to change. We've got our increase in preventable disease, increase in preventable premature mortality, increases in poverty. And against all those demand pressures, we're facing economic pressures as a country. Where I sit in the building, we have a live news stream going. I've seen Rachel Reeves being busy this morning, but I haven't heard what she said. No doubt she's trying to square the economic pressures that we face with the demands of our public sector. So we've got a sense of urgency, and my fear is that we have overwhelm and paralysis about that. The second fear is that we make the wrong decisions in the face of that urgent task. So today is really important in helping us to overcome that overwhelm and paralysis and wrong decision making in the face of urgency. So step 2 in leading coherent and good change is creating a guiding coalition, the willing people who take this forward in the same direction. And these are the people here today and everybody that we work with. So particularly appropriate day for us. And step 3 is our forming the strategic vision. And you'll all be hearing much more about the HDRC's missions nationally to embed evidence in the heart of local government, to understand much more about how we can use these public sector pounds to everybody's benefit in an effective and efficient way. So forming that strategic vision really is an important part of change, and HDRCs have a really important part to play in doing that. Step 4 is enlisting the army, the volunteer army. It's here today, but we can all go out and recruit more. We can spread the learning from today everywhere that we work. And step 5 is enabling action by removing barriers. I'll say a little more on that, but other speakers, as we get to the meat of the content, are really focusing down in on that, which will be really helpful. Step 6 is generating short-term wins. So I'll come back to that. Something really important on that, building acceleration and then sustaining that acceleration is our 7th step. And then finally to institute change, to make all the changes that we make become the new way of being. And here we have to work towards a new way of being, which is working together, using research to overcome paralysis and wrong decision making in the face of 21st century challenges as we sit here today. So we have got things that we can learn from the NHS, from the past, and I think when we're feeling gloomy and concerned about the future, let's just remember all the great things that have been research-based. We've had lots of evidence of what works, and we've made it work. So we've had our antibiotics, we've had our immunisations, we've understood that smoking kills. You know, when we talk about the NHS being one of our sort of flagship services, despite the long waits, etc., the science that it's based on is helpful. So we can feel positive despite the gloom, that we know that change does happen and evidence can work. So when we think then also learning from the past about evidence-based practice in the health service, you know, back in the 1990s, we were starting to think about, actually, we need to overcome some of the idiosyncrasies of individual clinical practice, overcoming the biases of individual clinical practice, working towards eliminating unwarranted variation. So this idea from the medical clinicians that evidence-based practice is the conscientious, explicit and judicious use of current best evidence in making decisions about care for individual patients. The practice of evidence-based medicine means integrating individual clinical expertise with the best available external clinical evidence from systematic research. And that concept kind of spearheaded this big change of actually medicine isn't just what people think they might fancy doing. It really is about rooting that into an evidence base, which has developed over time through adaptation into the 3 points on the triangle of evidence-based practice: best evidence, clinical experience and patient professionals. And in health, we've now got to a point where it's a concept fully embedded in our professional codes of registered practice. Professionals registered on the NHS professionals registers have duties to provide evidence-based care. And all of that is terrific in moving us towards safe, effective, high quality care with equity and great outcomes at its heart. So we move towards that and we move away from the idiosyncrasies and biases and errors of individual clinicians. So evidence-based practice, great. Next question, does it get used in the NHS? Where's our learning? So the short answer is not as much as it might be. We have many, many examples of the challenges of implementation. We know how hard it is, and there is a lot of research that we can take from the NHS to tell us why people are unable. So I thought I'd just spend a couple of minutes going through some of those and then try to focus in the last part of what I wanted to say on what can we in local government do differently. So thinking about evidence-based practice, does it get used in health? No, not really. Why not? Well, we've got a lack of time in the NHS, which obviously gets worse and worse. Some of that is clinical time, so it's quicker to write a prescription than it is to work on non-prescribing policies for things like sore throats. Terribly difficult to decommission services, terribly difficult for busy mental health professionals who are reaching for prescription pads to find other ways into their clinical encounters. There's also a lack of time in terms of people having simply no time to read. So people don't have that study time that you would need to stay up to date and across with everything that is there. There's the lack of resources. We know the sort of pressures in the health service in terms of how the money gets spent, lack of resources to fund people's study time. I mean, I teach people whose training is completely funded by the NHS, and it is extraordinary how very often they take all study leavers cancelled and they get pulled back into service delivery at the front line. So there's a lack of resources. There's also a lack of resources in terms of implementing change. You know, we know that some things will actually long-term save money. However, the short-term investment is very hard to carve out, and public health professionals don't need reminding of that very often the investment comes from one part of the system, the payback is to another part of the system. And we're talking always about, or very often about, demand reduction and not things that result in the hard cash, which makes sense for the accounting of the NHS. And then we know that people lack confidence in their own skills. So lack confidence in locating and critically appraising research, and that's a real issue for the ageing workforce in the health service. So we've still got staff who trained before the internet was invented, actually. So, you know, in terms of trying to do literature searches, in terms of critically appraising, that lack of resources and lacking confidence in those skills are really important. Then also a lack of interest in change, that at times of challenge, natural human response, head down, do it like it's always been done. So not an appetite for change. I'm concerned too that the evidence might not be out there, that it might not apply here, that you might spend a lot of time looking for things which actually won't apply in the local context of the local trust or the local specialist area. Then the lack of clear decision making, the recurrent question in the NHS asked by everybody from Florence Nightingale onwards: who's in charge here? Who's in charge? Who stops decisions? Who stops a discussion about the latest research evidence and how it can be implemented on the ward? Who is in charge? And we're not clear on that still in the NHS, I think. Also very defensive thinking. People worry, you know, they need to defend their practice in a court of law if necessary. They worry that if they make a change, what if it doesn't work? What will happen? So that defensive thinking, I think, goes along with professional registration concerns. Staff, lots of research on this post-COVID, have overwhelm and they've got used to moral injury. They've got used to working in settings where they feel they're not able to deliver the best possible practice, and they've got used to blaming others. They've become de-skilled, disempowered, so that it's the managers, it's the funders, it's the government. What they know is it's suboptimal care. They feel a sense of moral injury at having to deliver that, but they are not able to be empowered to take that further. And they've got used to reactive work. You know, the GPs are sitting there taking whatever comes in through the door. They find it extremely difficult to shift their thinking into predictive care, which of course would be the right way to change their working practice and to change demand, but they've got used to reactive care. So thinking about all the things that we know from the evidence are barriers to the implementation of evidence in the health service, what can we in local government do differently? And I guess, can we? We can, I'm absolutely convinced and clear, we can make it easier to base decision and practice on evidence. So why I think we can be confident we can make change well. Why do I think that? Local government has proved agile in making services. In making savings. So local government makes savings. It has to. It trims its cloth, cuts its cloth accordingly. It transforms services. It does that far, far quicker than the NHS, which simply runs at deficit. So local government has to do that. And quite sure if I was to ask Councillor Taylor, she would say that one of the most painful and difficult parts of being an elected member is not having the privilege of just unlimited budgets. So we can be confident we can manage change well. We do it. We're agile in making savings. We transform services. We can work at local level. So we don't have to chase the NHS holy grail of eliminating variation across the whole country, our national policies, etc. We can focus on what works for Sandwell, what will work right here, right now. We've got much shorter chains of command. So, and also we haven't got clinical, managerial, interprofessional hierarchies and rivalries. I feel that very, very strongly. The NHS can be extremely fragmented across professional lines, and it gets in the way of progress. It's interesting working as an interim for the first time in my career, how quickly you get a sense of a place. People here work for Sandwell Council, they work for Sandwell residents. That's who they work for. I think people wouldn't say I work for local government. I think people say I work for Sandwell. I work for Sandwell Council and I work for Sandwell residents. So we've got that really strong collegiate, shared approach. We're not riven with these interprofessional hierarchies and rivalries. We're not subject in local authorities to the same top-down command and control. We haven't got something scary happening with the minister who sends out an email on a Friday night telling us what to do, which is what can happen in the NHS. We can do things differently here. We've got our elected members setting our strategic direction, saying what they want to happen, and we have the freedoms, the possibility, the opportunity to do it, to make it happen. You know, so as officers, that's what we're here to do. So much shorter chains of command. So for all those reasons, I think that we can be really, really confident here in local government that we can do things differently and better in terms of embedding evidence into our decision making. So what I just want to do, last couple of thoughts on what we might do here differently. So firstly, we can do primary research here in Sandwell with our residents. I think this is sort of a bit like, what is it, evidence bingo or something, if you've got, you know. So, you know, when you know that it's the thing you're going to do or you're going to say, you can tick your bingo. So we can do primary research here in Sandwell with our residents. We've got an army of 4,000 staff here. We've got lots of people within the council who can deliver some of that for us, but we've got to have the thought leaders, we've got to have the methodological advisors, we've got to have the professional approach that shifts some people's gut feelings into something that may turn into a strong evidence base for a new way of working. So we can also do evidence reviews and we can spread the learning. I always, in teaching, go back on this sort of the very slow accumulation of evidence on babies' sleeping positions. So gradually, you know, from the 1970s onwards, there were lots of studies on the links between babies' sleeping positions and sudden infant death. But it wasn't until we had a systematic review in 2005 that it was accepted that the relative risk of sudden infant death for front sleepers was 3 times that of babies put to sleep on their backs. So had that review been done in the 1970s, it's about probably 60,000 babies' lives that would have been saved had that happened worldwide. So there is no excuse for not building our own evidence base and having that short line of command between strong evidence from the reviews that we're pulling together and actually decision making. So we can make it easy for our elected members and their advisors. And summarise the evidence on what's likely to work here. We can also empower our staff, our local authority workforce. We can reach all of our workforce here in Sandwell. This isn't the million-strong workforce that the NHS is trying to shape and organise. We can reach everybody. And when we come to training our staff in literature searching, framing questions, critically appraising evidence, that training, we've got the power to put that into job descriptions, into the required training that people have to do. We can also infuse our staff with thirst for that knowledge. You know, there's a very clear leadership within local authority, both from the elected members, but also the office at core. People coming together in large groups of leaders who can lead change, going back to what I was talking about in the beginning, applying the science of change leadership. And what we can do too is to work with elected members to bring published evidence to their in-depth knowledge of local communities. Our elected members are a fantastic resource with years of experience of living here and knowing this place. We can build a much wider evidence base to complement that knowledge, and we should be able to find that sweet spot of strong evidence, both published evidence and known evidence. So what else can we do differently? Final thoughts. We can make sure our decision chains are short. We can find out what works. We can bring that to our local authority decision-making processes really quite short compared to the NHS. Our elected members are responsive, action-focused people with a really strong commitment to improve the lives and outcomes of local residents. We can maintain positivity and confidence, empowering everyone in our Sandwell local authority family to make sure that decisions are made on our best possible evidence, be that at individual, community or population level. Probably many of you have heard of the Sandwell story, new initiative, new campaign work, changes that are happening here as Sandwell moves through the 21st century into better times. There are better times ahead for Sandwell, and evidence can be the motor for the decisions that bring that change at pace. So welcome to everybody today to Sandwell and to this event. Thank you very much indeed to all the speakers, and simply to repeat, this work is really, really important work.
Thank you, Frances. That was a fantastic call to action for us all to embed the evidence base in all the work that we do. We've got 15 minutes now, so I'd just like to offer it out to the audience if there are any questions for Frances and Councillor Taylor as well. And if you could just start by introducing yourself, I think that would be really helpful for the speakers too. And you can put some questions in the chat as well if you'd rather note them down than speaking. Okay, it's a lot to take in, so I'll give you a few minutes. I think one thought that I had during that presentation, Frances, was around, do you have any examples within your own career where you've used a really valuable piece of local evidence or local research that a team has conducted to perhaps do something very differently within public health or the public health work that you've been conducting?
Well, yes, social isolation, that was one. So that was something where we collaborated. It was a big piece of work with an innovative use of social impact bond funding, which was from the Cabinet Office, so under a previous government. And we worked with UCL in order to measure that. And what we were looking to do was to understand how to break down social isolation amongst older people on the knowledge that that would mean that they would remain better socially connected and less likely to come into a need for services. So we set up a way of working which was done with the VCS partner called Connections Project, and it was early days. You know, this is something that is done much more routinely now, but it was going in, taking referrals from frontline services and going in and reconnecting people to communities, or connecting them for the first time if they were people who had been disconnected and for whom that was not a problem until there was a life change, like bereavement, divorce, loss of a job, those sorts of things. And the model was based on that one-to-one work, but also then on volunteering, so that people who went through the process then became volunteers. And UCL did our evaluation on that, and that demonstrated impact such that we were able to translate that model of working into some of our ongoing work on social prescribing. And again, social prescribing then was very carefully measured in terms of impact. And I guess with social prescribing, I always say, you know, there's an example of something that we were told top down to do, or the NHS was told top down to do in the midst of a sort of evidence vacuum. But you know, nonetheless, not the first time that's happened. But the social prescribing piece gives us that example of we have to be careful what we're measuring and why, because people do a lot of measuring social prescribing in terms of contact with GPs before and after an intervention, and you can usually measure that there will be a reduction. What you need is much more long-term data in terms of understanding whether that reduction of visiting the GP is helpful or not, because it could be that people have been diverted and think, well, I'm not going to go and see the GP because they're just going to tell me to go and join the local knitting group, you know, so this lump in my breast will just have to go unnoted until my next mammogram. So we still need some long-term data on social prescribing that helps us to understand whether the reduction in visits, and that really requires the onward interrogation of clinical records. So that would be an example of that piece of work that began with something innovative, translating forward into our mainstream practice, but remaining under investigation. Evidence also gives us, I suppose, permission to think differently. So where we have something, this is not popular, and don't forget I spent most of my time working for what would see itself as a fairly right-wing Conservative administration, well, at a time before the public narrative had shifted quite so far to the right. But we were taking money out of early help and children's services, and we did a lot of looking at who used children's centres and why, and on the back of that felt very confident to make proposals about reducing funding for certain centres. So where centres were reaching middle-class people who were driving up in their 4x4s and having unevidenced interventions like baby massage or homeopathy, we didn't feel that that was a priority for local authority funding, and we felt that we could sort of square the moral circles on that because of the evidence base that we had, which enabled much more of a focus on the people with the highest levels of need. Oh, there's a question there.
Question in the chat. Yeah, I think that's from Hannah, who works for the Black Country Mental Health Trust. So how is Sandwell Council embedding community-led insights into its long-term public health strategy, especially in relation to underserved populations? So brilliant question, Hannah. I think one which Frances will very much love to answer.
I think this is very challenging because I think our community-led insights, you know, it's very hard to define, isn't it? And I've struggled with this a little bit at Sandwell because there is a narrative about our very strong community voice. There's a narrative about consultation and co-production. I don't quite see the evidence of that in terms of numbers. So we do have to be really clear when we talk about community-led insights that we're not just listening to the sounds of the loudest voices from very small numbers. And I think that methodologically we haven't quite got there yet. So I don't think we can say we've got body of evidence, which is community-led insights. I think what we can say is we've got a lot of intention and wish to hear the voices of underserved, failed to reach populations, but I'm not sure that methodologically we have found a way into all those communities, and we have some communities that are very difficult to reach in terms of the barriers around ways of living and barriers in terms of language, which I can see that Councillor Taylor wants to come in there. So I was just going to say that we are in the cycle of preparing our next health and wellbeing strategy, and we will be going out to have some focus groups with some of those services, some of those populations, so that we can feed those views into our consultation process.
Thank you, Frances. Councillor Taylor, please come in.
Yeah, thank you very much, Anna, and thank you, Dr. Harry. I just wanted to say that you can't underestimate the work of us elected councillors, and yes, it is difficult to get those difficult to reach communities to engage with the council and to engage with research. But if it means that drip, drip, drip approach, that is the approach that we're going to use, because it's really, really important. I would class myself as a councillor that's on the ground with my residents. That's not unique to me. There's a lot of councillors that actually work very much in the same way. And so I just wanted to say you cannot underestimate the interaction that we have with our residents, with our communities. Thank you.
Thanks, Councillor Taylor. And yeah, I go back again to your quote around speaking the language of community, but I think in terms of, again, how we embed community-led insight into our long-term public health strategy, just for Hannah, I know you work for a hospital trust. We meet with Councillor Taylor here every week and brief her on the work that we're doing. So we're constantly receiving that feedback from what Councillor Taylor has heard from her community into the work that we're doing within the team. So yeah, just one last question. We just have about 5 minutes left, and that's from Joan, who said that she doesn't understand why some communities are hard to reach, and can someone explain?
Well, I can explain, Anna.
Yeah.
When perhaps hard to reach is not the right terminology.
No.
But what I can say is that there are some people who are residents in Sandwell, and I can speak for the Black community as a good example. I can speak for our young Black youth here in Sandwell that are quite suspicious of organisations. They're quite suspicious of the structure. Remember, if you can't see it, you can't be it. Yeah. And, these are people that won't engage due to being very suspicious, and also suspicious on what you're going to do with the evidence. Yeah, a bit like COVID and the pandemic that we had. So that's exactly what I'm talking about.
Thanks, Councillor Taylor. Frances, did you want to come in on that, or?
Yeah, I mean, I think, the easy to ignore or the not trying hard enough, those things, I mean, those kind of almost go without saying in my mind. I mean, I think we know that we have large populations in Sandwell who are not engaged in the public realm, if you like, and everybody, I'm sure we've all got a shared wish to gain insights from that group, to serve those groups, and it is extremely difficult. And I think that it's Councillor Taylor's alluding to some of the sort of historic racist barriers in the way for those people. And I think it isn't as simple for us as just saying, how can we do it? Communities are contested places, and there's no such thing as a a community. And we have a network of community development officers, we have community development workers, we have local council offices, we have integrated neighbourhood teams from the council who are able to serve the needs of some of the people that live there. But, you know, if I had to have one methodological wand to wave, it would be to understand how can we overcome some of those barriers for some of the populations whose voices we don't hear. And we certainly are not there yet.
Thanks, Frances.
Yeah.
I think.
Sorry, just a final thought.
Yeah.
You know, something like, you know, I suppose it's how the debate's moving on quite rapidly. So, you know, we think about translation services, don't we, and things like that. And I think things, again, trying to keep up positivity and confidence. You know, we've moved a long way because people can actually get things translated through the information that's on the website. We have got link workers, we've got the Sandwell Language Network process. So we've got some things, so we have made some progress, but it feels to me that there's a sort of shift that is needed, and we could do some evidence to support us with how to do that in quite difficult times.
Definitely. Lena?
Hi. So Lena Martino, I'm a consultant in public health and director of our health determinants research collaboration. So one of the things that's come out through our work with the HDRC is obviously we use links with the voluntary sector quite a lot to reach communities that we've typically not engaged enough. Now, obviously, a limitation there is that whenever you are using voluntary sector time, you need to appropriately reimburse that time. There needs to be sort of funding and investment into doing that work. One of the things we are doing with the HDRC is we've developed a payment policy. So for when there's public involvement, we can reimburse people appropriately. And similarly, we can also make payments to voluntary organisations in lieu if that's if people would prefer that. I think one of the things that has come out recently, and I know the council's done a lot of work looking at its relationship with the voluntary sector and the grants process, is that very often it's the same organisations that get involved and there isn't perhaps an equity of involvement. And I know the council's done quite a lot of work to look at that, to sort of try to build that in more.
Thank you, Lena. I think I'll finish that discussion up there. If you have any more comments on that or questions, just please put them in the chat and we can kind of continue the conversation as we go along. But I think that leads us very nicely on to the presentation from Professor of Public Health and Knowledge Mobilisation and co-lead of the NIHR first team, which I was going to try and remember what that acronym stands for, but I think I'd better just hand it over.
Yeah, don't worry, Anna. There's plenty of acronyms going around. So thank you very much. Good morning. Great to be here. Thank you for having me and inviting me to your party, so to speak. So I'm Peter van der Graaf. I'm based at Northampton University in the northeast of England. And I'm sort of passionate about knowledge mobilisation. I work in various research infrastructures in the region and nationally to both do knowledge mobilisation, but also to research knowledge mobilisation. And some of those infrastructures I mentioned, so I'm involved in the applied research collaboration for the Northeast and North Cumbria, but also in FIRST, the public health intervention response study teams. There's 10 of them now, and they are a resource from NIHR to help local authorities evaluate their public health intervention. So please have a look if you're interested in that. And I'm also involved in FUSE, which is a partnership between the 6 Northeast and North Cumbria universities around sort of translational public health research. So what I would like to do here today is reflect on some of my experiences in those infrastructures in doing knowledge mobilization and from the research. Why is it really so hard to do, and how can we make it easier? And I would welcome sort of discussion reflecting on your own experiences in this space and how we can help each other. So without further ado, can I go to the next slide, please? Whoever is going to hear, thank you. So I'll start with a bit of a a story to outline, I mean, what friends have already started talking about, so the knowledge doing gap in research and knowledge mobilization. So this is a story about a man in a hot air balloon, and he realized that he was sort of lost. So he did the usual thing. He reduced his altitude and spotted a woman below walking on a field. So he came lower and shouted, "Excuse me, can you help me? I promised a friend I would meet him, but I don't know where I am." So the woman below replied, "You're in a hot air balloon, hovering approximately 30 feet above the ground. You're between 40 and 41 degrees north latitude and between 59 and 60 degrees west longitude." "You must be a researcher," said the balloonist. "I am," replied the woman. "How did you know?" "Well," answered the balloonist, "everything you told me is technically correct, but I've no idea what to make of your information, and the fact is I'm still lost. Frankly, you've not been much help at all, and if anything, you delayed my trip." The woman below responded, "You must be a policymaker." "I am," replied the balloonist, "but how did you know?" "Well," said the woman, "you don't know where you are or where you're going. You made a promise which you've no idea how to keep, and you expect people beneath you to solve your problems. The fact is you are in exactly the same position you were in before we met, but now somehow it's my fault." Next slide, please. So this is sort of a bit of a stereotypical story, but it highlights there is something like a gap between knowing and doing, between researchers, practitioners, and policymakers on the other side. And if we sort of delve a bit deeper, we can see that relates to different ways of working. So researchers are interested in answering research questions and exploring the unknown, while practitioners are more focused on solving practical problems and are interested in what works. Academics publish papers and they are assessed on the number and qualities of papers that they publish, while practitioners are more involved in writing reports or look at patient records and are assessed on the outcomes of patients or residents in their area and the financial efficiency of the services that they commission and provide. Academics really are interested in rigorous data collection and take a lot of time to analyze their data, and see evaluation as not really proper research, while practitioners have to work under pressure to deliver quick wins. Frances talked about this already sort of in her presentation, and they see evaluation improvement as really valuable activities in that process. So different ways of knowing and doing between the two that contributes to that knowledge and doing gap. Next slide, please. So as a consequence of this, we know from research that it takes very long and it's very slow for research to move into policy and practice. So it takes on average 17 years for only 14% of research to get into policy and practice. So that means that a lot of research is just wasted, is not used, is staying on the shelf, as the councillor referred to. Even worse, about 30 to 40% of patients do not receive evidence-based care, and 25% of patients receive care that is unnecessary or even harmful. So there's a lot of waste and bad practice going around based on not using research and other types of evidence. Next slide, please. We also know from that same research why that is the case. Why is it so difficult for that research? Why does it take so long, and why does so little research makes it into policy and practice? And the one thing is, Frances already talked about some of these. Academics are brilliant at publishing their papers after recommendations have already been made or policy has already been developed and implemented. So they simply take too long to report their findings. Academics are also brilliant at pointing out what the problems are, but not always very good at pointing out what the solutions are. So their research doesn't contain any actual recommendations. And they also have their pet projects, so they focus on particular issues that might not be relevant or fail to address the most pressing local issues in a local authority area. And then from the other side, even if there's research evidence available on a priority area or a local topic, it still has to be adapted to local context. How do we make it work here in our context with limited resources and existing infrastructures? Evidence might not even be available, and also when it's available, how practitioners might lack sort of the skills of using that evidence in searching, appraising, and synthesizing it. So there's lots of issues both from the pool. Sorry, can we go back to the previous slide, please? Thank you. I want to address one sort of big elephant in the room that particularly researchers are not really aware of, that research evidence is only one small piece of the puzzle in what informs decision making. So there's other types of knowledge that come into play and often trump what decisions are being taken on. So, for instance, technical expertise, so the practical skills, experiences, and expertise of frontline staff, the practical wisdom, professional judgment, values, and beliefs of policymakers. So, if you're not aware of that and not counter them in and blend the different types of knowledge together, you will not have a very good job in informing decision making through research evidence. Next slide, please. So how do we close that gap between knowledge and doing? So there's two different schools of thought that have emerged. One is around sort of the push. We need to push out research findings to the people that need them. So academics publish papers, but also try to do policy briefs and try to do presentations to practice. So they push out the evidence, and this is sort of where implementation science come from, in looking at identifying best practices, best approaches to implementing evidence-based innovations from research. And then there's the pull school of thought on the other side, where practitioners look at the existing evidence base and try to pull that in to address practical problems that they face in their daily work. And this is where a lot of quality improvement approaches come from. So using evidence from research, but also lots of other sources to improve the outcomes of particular service provision. Next slide, please. But why can't it be a bit of both? Why can't it be both pull and push? And that's where we start talking about knowledge mobilization, knowledge exchange, and working much more in co-production and partnerships around the available evidence base and different types of knowledge. And one of the definitions that I like to use to define knowledge mobilization, because there's so many different terms banding around this, is one that we developed in the Knowledge Mobilization Alliance. And this sort of highlights that knowledge mobilization is about bringing diverse communities together to share and create new knowledge in the context of its use to actively change something. And there's some key elements in here. It's about bringing different groups of people together, so both the producers and users and intermediates of knowledge, of research evidence. So that includes academic researchers, practitioners, policymakers, local communities. And you do that to share knowledge, but also to create knowledge, and particularly in the context of its use, to make it relevant and timely and accessible, but also with a clear goal to change something. And how can that evidence be used to change something? One particular thing I would like to add to that definition is sort of what's underneath that is, it's not necessarily for me about bridging a gap, but it's more about blurring the boundaries between knowledge producers and knowledge users. And I think that's something also that HESCs are really trying to do in their practices. Next slide, please. So one thing we've done within FUSE, the Centre for Translational Research that I'm involved in the Northeast, is we experimented with different ways of trying to do that. And over 10 years came up with sort of a model that reflected on 4 key steps that we think are important to think about when you try to do knowledge mobilization. And they're sort of iterative steps, and you can move up and down the ladder in a sense, but they try to combine the push and pull approach by first looking at sort of awareness raising around research. So our knowledge users are the people that we work and serve aware of the research that we're doing. So we've got a dedicated communication officer who is very active, maintains a big website as a shopping window, has a lot of activity on social media to push out a lot of the evidence that's being generated through our research center. But that in itself is not enough, and this is where a lot of activities usually stop. What we discovered, it's also important to then create opportunities for research users and producers to come together to sort of explore that evidence and create shared meaning and learning around that evidence. And that's where we organize a lot of events, usually led by policy and practice partners, where we ask them what keeps you up at night, and can we organize an event that brings together the expertise from various people on how we can try and solve some of those nightmares, and or what research we can develop around this. But again, that's not enough in itself. If people understand and share the evidence, it's also about making evidence fit for purpose. And this is where step 3 comes in. So it's about localizing and tailoring evidence to the context in which it's needed. And that's where we developed a brokerage service, Ask FUSE. We had a dedicated knowledge exchange broker, but we also work with embedded researchers to really sort of bridge the context between academia and local government. And I'll say a bit more of that in a minute. And then the final step was about sort of supporting the uptake and implementation of the evidence once it's being localized and tailored. And this is all about sort of the long-term relationship, something that Council also highlighted in terms of it's about people and community, how we bring those long-term relationships and sustain them, how we build capacity for people to understand, use, share, and embed evidence. And again, you're doing brilliant stuff around that already within the HDRC. And these steps sort of can work in different ways. So you might be able, so you're sharing knowledge in conversations with various stakeholders, and from that, there's a query about different types of evidence that you want to raise awareness about. So you can move up and down these steps. But this has been helpful for us in thinking through what we can do and how we can structure our knowledge mobilization activities. Next slide, please. So to give you some examples of these steps from work I've been involved in. So around awareness raising, we use a lot of creative communication to raise awareness. So we developed briefs, policy briefs, 2 pages, quite visually, pictures, but also lots of actionable messages around what can we do, what can policymakers and practitioners and researchers do to address this problem. We have a very active blog, which is a way of sharing very practical experiences about working with research and also some of the challenges in working with research. We have an active team of podcasters led by our public engagement and sort of the community members who sort of interview researchers about their evidence and how it could be applied and used. We use stand-up comedy around sort of obesity management. We used theatre to really visualize and bring to life the stories of local communities and what the research means to them. We've used animation and gaming, apps, infographics. So there's a variety of tools in a sense that you can use to raise that awareness beyond the box standard academic paper. Next slide, please. The third step I want to highlight is sort of around making evidence fit for purpose. And here we used a lot of embedded research posts. So these are co-located research roles within sort of the local authority public health teams. And within that sort of co-location, they co-produce the findings to make it fit with the organization's unique context and culture. So by working in the local authority public health team, they get a much better understanding of the needs within that setting and how they can tailor and adapt the evidence, but also bring in new evidence and build capacity within the public health team about research. And finally, that's about working across organizational borders and blurring the boundaries in a sense between the producers and the users of evidence. So we found that these roles, embedded research roles, are a key mechanism for making evidence fit for purpose. Next slide, please. So if I apply that sort of model and thinking to the HDRC in Sandwell, I can see there's a lot of stuff already happening, and maybe we can have a bit of discussion later on how you feel that applies. In terms of awareness raising, there is a website that you're developing. You probably think about a newsletter and publishing your work and what you do on social media. So there's activities happening around awareness raising. Similarly, around knowledge sharing, that there's been community roadshows organized, there's workshops being planned, wider learning events, but also a shared data system across different organizations to really help share that knowledge that you have, but also create conversations around that knowledge and how it could be applied. And then step 3, I think, is where maybe we can do some thinking and development around how do we make it fit for purpose. And one thing we've used within Fuse and other infrastructures is around developing particular knowledge mobilization plans for each project, thinking through how do we want to mobilize evidence with our local stakeholders. And using embedded and also peer researchers. So we got an active network of peer researchers who act as champions for their communities, but also bring in the voice from their communities in the research, but also gain more insight in research as part of that role. And then finally, step 4, the supporting uptake and implementation. You're looking at developing training programs, so that capacity building, that's really key, and already working together with universities and local partners. So how can you build on those relationships and extend them, and also involve the community actively in this, particularly in underserved areas where we've just been talking about. So there's work happening in all these 4 steps, but how can we enhance that and link them more across? Next slide, please. So a quick example of what a knowledge mobilization plan could look like, and this is what we've used in various infrastructures. I use a template here that's been developed by the Knowledge Institute for Child and Youth Mental Health and Addiction in Canada. They developed a knowledge mobilization toolkit, which is sort of a template that asks a few simple questions about your project, your research, and how you could mobilize the evidence within that. So, for instance, what is the knowledge that you want to mobilize? What are some of the key messages that some of your stakeholders need to hear? And then what is the goal of mobilizing that knowledge? What are you trying to change? So thinking about that upfront in your research can really help define how you include knowledge mobilization activities as part of that. So also the why. Why are you interested in mobilizing this knowledge, and what are you aiming to do? Is it more about educating or inspiring, motivating, engaging? So being clear why you do it, and why these messages are important to your audiences you're trying to get these messages to. And then the who, so who's involved in both receiving the messages, but also in sharing the knowledge that you're trying to mobilize. Who are your partners in this? Who are your champions in communities, in organizations? And who can help you share that? Who can be engaged in your knowledge mobilization activities? Because it is really a collective effort rather than by the few. Next slide, please. And to continue some of the questions that the knowledge mobilization plan and template is asking, and it also suggests really practical actions that you can respond to in each of these questions. So it's well worth a look, and I'll include a link in the end for the resource if you're interested in it. Other questions about the how, the when, and how do we measure it? So how, once you've sort of defined your messages and your audiences and who can help you, how will you then deliver your message to that audiences? How will you engage with them when developing these messages and also doing your activities? And that's where some of the ideas from the Fuse model also come into play with the different steps. Timing is important. So when do you want to mobilize this, and are there opportune moments to do this? Other activities or conversations, meetings taking place that you can tag on to influence the uptake of the knowledge that you're trying to mobilize. And finally, something that's often overlooked, the measuring of the impact of knowledge mobilization, which is the whole point of knowledge mobilization. How do we generate impact and change? But how do we know that we achieve the goals that we set out at the beginning for our knowledge mobilization plans? What useful evidence indicators can we collect to demonstrate that we're getting there? So what evaluation questions will produce meaningful findings, and how can we incorporate this in our research on knowledge mobilization? Next slide, please. So that's a practical example, but it doesn't mean we can solve everything, and there will still be challenges around knowledge mobilization, and I've listed a few here. One is around the lack of structural incentives, particularly in academia, but also in local governments to support knowledge mobilization. So how do we make this a viable career option and pathway for people to work in? There's a lack of training in what I call the craft of knowledge mobilization. It's not something you can learn and pick up in a quick 2-day or even 2 weeks course. It's a craft you learn by doing, and you learn from mistakes. How do we build that into the curriculum, and how do we provide time out for policymakers and practitioners to develop that craft? There's also a lack of leadership to support and resource knowledge mobilization, both in academia and in local government, and a lack of mentoring for embedded researchers, peer researchers, and a community of practice to share some of the learning and also the failures. I'm a big fan of thinking about failures and how we can learn from failures to improve our practice. The last thing is about the lack of research on knowledge mobilization practices. So, and this is where sort of the toothbrush problem comes in, which I quote from Vicky Ward and Karen Ritchie, that everybody has a theory of model around knowledge mobilization, but no one really wants to use anyone else's model. So how can we become better at using what's already there? And a lot of the research looks at sort of how it should be, but not what it's like and how it could be done, or what it. So can we have more practical research on how to apply these models and learn from each other's work in this space? Next slide, please. The last one I want to end on a bit of a positive note is that I think we can also make it more fun. Knowledge mobilization to me is both a science and an art, and so I use a metaphor of a dance. It's not only about learning the steps, there's the science of a dance and choreographing a dance to blur the boundaries between sort of knowledge producers and users, but it's also about the art of performing the steps, and that to me brings in things like everyday skills. It's about listening, it's about emotional intelligence and persuasion. It's about relating knowledge to people's sense of self and how to make it relevant to them. And often overlooked in that are, I think, feelings, emotions, how emotions play into implementation barriers and difficulties in getting knowledge mobilized. And this is where sort of the misperceptions about stubborn practitioners and lazy scientists come in. So scientists blaming the stubbornness of practitioners for insisting on doing it their way, believing they know their patients best, while practitioners sort of lament the smugness of scientists who believe that they publish it and then practitioners will use it. And so these misperceptions signify really emotions at work in the knowledge gap that need to be addressed before we can really start mobilizing knowledge. So attention to feelings and how knowledge makes people feel is, I think, very important. Can it energize? Can we be passionate about this? And that means developing an instinct for where you are in the dance state with the metaphor, and spending time in each other's context, which is sort of where peer research and embedded research comes in. So in short, can we be more at balls, have a bit of fun in the dance of knowledge mobilization? Next slide, please. So I'll stop. There are some resources here if you're interested in some of the things I talked about, the templates about knowledge mobilization and planning for that. The toolkit is mentioned there. The next slide will mention some references if you're interested in reading some more about the stuff I talked about. But at this stage, I just really want to say thank you for listening to me. Hopefully this gives you some food for thought, and I really welcome a discussion about your own challenges and experiences in this way. Thank you very much.
Thank you, Peter. I thought that was a very funny presentation, or the start of it. I really liked the hot air balloon story, and again, it kind of comes back to a golden thread within our presentations today around language, and then showing us the toolkit at the end. I think that's a really practical way that we can do knowledge mobilizations ourselves. So thank you for that. Do we have any questions? We've got, we're going for a break at 11:15. So, yeah, let me know what you've got. Lena?
Yes, thank you so much, Peter, for that really excellent presentation and very entertaining. So what struck me was, you were talking about researchers and sort of having their own interests, and particularly, I suppose I got the impression of maybe not wanting to engage with decision makers. Actually, I come from a research background. So I was actually a researcher before I came into public health training and then became a consultant. And one of the things I actually found the opposite. I found that really most of us were crying out for our research to be adopted and taken into practice. We really wanted to get involved in making recommendations that could be, practically applied. But actually, there were so many barriers there in terms of making those links with policymakers. And what we're finding with the HDRC is very much the same thing, that actually, we've got a lot of researchers, and I don't know how common that is, but we certainly find we have a lot of researchers getting in touch with us who are really, really keen to do research that has real world translation and real world applicability. And I suppose really, I'm just interested to, from your perspective, obviously we have HDRCs, which have gone a long way to sort of starting to build those bridges, and there are numerous other opportunities coming in. But is there anything else that you feel might be helpful in sort of getting academics more involved when they want to be?
Absolutely. Great question, and absolutely, it's. I was trying to do a bit of a stereotype in a sense to highlight the two communities, but in reality, those communities overlap quite significantly, and there's lots of people with an academic career that move into local government, and the other way around. So there's, in a sense, there's more common ground in a sense, but they still live in two different systems with different incentives for what's being encouraged and rewarded, and so there is a clear appetite among researchers, and particularly I think what more sort of early career research is coming through in really working closely with partners and politicians in local government to embed and implement their evidence. But there are these sort of system barriers in how you do that, and I was sort of trying to unpick some of that in terms of the difference in timescales and the difference in sort of the focus of the research and the incentive criteria within those systems. So it's being mindful of those barriers, but absolutely understand that there's a great willingness to work in that collaborative way. And I think there's a lot to be gained from partly realizing that on both sides of the gap, if there is even that much of a gap. It's but also because I think in local authorities that there's a lot of research expertise and capacity. A lot of people have been involved in research, or what I would call research. They might not call it themselves in that way. They might call it evaluation or audit, but there's clear learning and evidence, and I think recognizing that and capitalizing that is really key. But that means also understanding those already existing barriers that make it so hard to do that. So I think the first step for me is a conversation about that, and so what makes it so hard for academic researchers to do that, and what makes it so hard for people working in local governments to work with researchers, and from that you can clear up a lot of misconceptions, I think, which was what I was trying to allude to in my last slide. So absolutely, recognizing that and building on that is essential. So yeah, thank you for that.
Thanks both. Did I see Lois? Did you have your hand up? I think it went back down, but feel free to ask
there's
a
a
question
comment
if
in
you'd
the
like to.
chat as well.
Yeah. Okay. Oh, it was answered.
Yeah, it comes back to the earlier question about
Yeah.
well, hard to reach community. I in principle I don't like that term because it puts the emphasis on it's the community's fault that we don't reach them, and I would like to flip that coin, and so it is our fault we're not able to reach them. So what can we do differently to reach them and reach them better? And absolutely, I think because to me, community engagement is a big part of knowledge mobilization. So some of the practical ways that I've tried to outline in my presentation apply equally to community engagement and thinking through the steps for that. So I wouldn't want to separate them. I think that there's a lot of common ground in there, and they should be part and parcel of the same approach.
Thank you very much, Peter. I wonder if this is a good time, if there's no more questions from the audience. Your presentation sort of tracked our journey in Sandwell Public Health team from having an embedded researcher from first, which I think was almost the start of our big HDRC or research journey, into actually being at the end of the first year of having the HDRC here. But I know, Jane, you wanted to kind of just come in and speak about the video that you had created on the research that you have done with local Sandwell women around perinatal mental health, and that will just take us on into the break, which is at 15:15. But go ahead, Jane.
Thank you, Anna. Thank you, Professor Peter. That was a fantastic presentation. With regards to knowledge mobilization plan, so for this piece of work, I also drafted a knowledge mobilization plan. But one thing I noticed was when I started to implement the activities on the plan, not everything suited with the women from the community. So is there an opportunity for stakeholders to also input on the toolkit that you've shared or on the plan, before it's been
Absolutely.
implemented?
I think the best way to complete that template, to develop that knowledge mobilization plan, is do it as sort of a co-design, co-production process with stakeholders, including community members. So get their input on what they take away as as important messages or audiences, and how best to reach them, and how to develop the mechanisms and the measurement of that. So it's absolutely, I think this. I mean, you can do it different ways. You can have a first go in doing a draft, but then use it as a discussion piece for various stakeholders to get their input, or really co-design this from the start to make it being led by communities about what they feel is important about the research to mobilize. So absolutely do this with, and to me it's a tool that can be changed. So it's a template, but it's not set in stone. So it's all about how do you create it as a living document throughout the projects that you deliver, or activities that you develop, and how do you update as you go along. So use it as a reflection tool. How are we doing? Is it still working? Do we need to change course? And I think that's also a way to keep that conversation going.
Yeah, thank you very much.
You.
Thank you. And as part of that, we did develop a video that's for that project. So I would like to share the video. It's an animation developed by a year 10 student. It brings to life the voices of the women. enjoy.
And Kira, just before you play that, I would just like to say that now is the break time. So we've got 10 minutes. Everyone can come back at 25 past, or if you've got your cup of tea at hand, you can sit and watch the video, which will be played during the break that Kira is just showing up on the screen. So thank you so much, all the speakers in the morning session. It's been a great day already. But yeah, we'll see you at 25 past.
We bring a prescription. It's in a prescription. My own. Welcome back, everyone. I hope you had a good break. And
there was a chance again to watch Jane's video on the research that she's done around women's experience of perinatal and postnatal mental health. She's just posted the link in the chat. So please use that and share it widely with your colleagues in your communities. Next up on the agenda, so I think there's some people who may have just joined us for the next part of the agenda. So just to repeat my housekeeping rules from the start of today, can everyone just make sure they're on mute so there's no background noise when the speakers are talking. And for any speakers that have just joined us as well, just a reminder that your presentations have both time for the presentation and questions and answers, and I'll just give you a 5-minute warning if needs be before we're coming up to time. So we've got 3 items up next before the lunch break, and one is from Dr. Dimitri Nepogadiev. I hope I pronounced that right, Dimitri. And that will be on local perspectives, as well as our very own Dr. Lina Martino also speaking about local perspectives. And it will be summarised during a panel discussion at the very end as well. So firstly, Dimitri is consultant in public health and associate professor in public health, both at University of Birmingham and Birmingham City Council. And he'll be speaking to us today around what can universities do to bridge that research gap. So Dimitri, if you'd like to go ahead with your presentation, welcome.
Yeah, thank you very much for the introduction, Anna, and a real pleasure to join everyone today. So this is the title I was given, Bridging the Research Gap Between Communities and Local Authorities. So what I thought I'd do is kind of talk through the research cycle and where the university can add value throughout that cycle. So really, in my mind, what does the research cycle look like? Decide what we're doing, setting the priorities, what are the important research questions we need to answer. And that might sound a bit trite, but it's actually the most important part of the whole process, to be honest, because if we don't ask the right question at the very beginning, then it doesn't matter how brilliant the work we do subsequently, we won't necessarily come out with the data that actually makes a difference to our communities. So it's really important that we spend lots of time thinking about what is the research question that is really important to our community. Having decided that, the next most important thing, to be honest, is the study design. So making sure that we're applying the right methodology to address that research question. Then we need to deliver the research, analyze the results that come out and interpret them to understand what the data we've generated means. And I think we heard in the last talk around the importance of making sure we then disseminate and produce an impact with our data. What are we actually going to change to benefit our communities as a result of the work we've done? So I'll go through each of these in turn. But before that, really to just say that research should be a process that brings together lots of partners, and that includes the patients and the public. You got that sort of quote there, no research about me without me, and that's really important, that whatever we're focusing on in our research, we need to make sure that the relevant communities, patient groups are engaged from the very beginning, to make sure that we're designing research that is going to be really meaningful and producing outputs that are going to positively sort of impact on their experience. Then we've got voluntary, community, social enterprise and faith sectors, and they're really important partners, because actually one of the ways that we can engage with the public is through the voluntary sector and the faith sector. So that they're important partners to bring on our research journey. Of course, there's a local authority, but again, we need to think about how we engage really across the council. So it's not just a public health activity, but, and I think that HDRC has been working really hard to achieve this, it's how do we engage other departments within the council. That could be social services, that could be environmental health, that could be housing, and so on. Particularly those councils that have the most impact on what the wider determinants of health look like. So, for example, housing is a huge one, but perhaps a bit less research, less of a tradition of research, perhaps, in some of those departments. So it's bringing those along with us and making sure we're engaging with them. Researchers, well, I think it's important to note that researchers aren't a monolith in the sense that there's a lot of very specialist methodological and research skills. And so you need to make sure you're speaking to the right researcher. That there's people who have expertise in statistical analyses, people who have a background in qualitative research, implementation research, health economics, and so on. So we need to make sure that we bring all the right combination of people with us who are going to be able to support us on our research journey. And that, of course, is where the university has a big role, because we have a big university here in Birmingham, which is interdisciplinary, and we probably have most of the expertise you might ever think you might need. But it's a question of reaching out to the right people. And of course, engaging with our wider system partners and stakeholders, because we might be quite reliant on them to do some of the implementation of the findings of our research. So we need to make sure we engage with all of these people from the very beginning. And the beginning is where we're setting the priorities. Now, perhaps we might have some sort of needs assessment that has already been done ahead of time, or we might do some quick needs assessment at the beginning. So we're interested in, for example, housing and health, but what are the specific gaps where services need to be improved and where there's a lack of evidence on how to achieve that improvement. So one of the areas here is around how do we improve data sharing between universities, local authorities, communities, to make sure we're bringing together all the data and insights that can help us to build up that picture of what the needs are. That needs to be a process that brings deep community engagement and centers lived experience. Councils have very strong community engagement functions, but I think where universities can support is we're probably a bit more used to how do we engage public specifically around research. So there's probably a bit of university can learn something from the council in terms of how to engage, but probably the council can learn from the university around research engagement specifically. And then how do we go through that priority setting process in a structured, transparent, and inclusive process? And there are various techniques that we use commonly in the university. That could be Delphi type techniques, nominal group techniques. So I think there's a bit of methodological exchange there around how do we make that engagement really robust. And then working together, we need to develop a PICO. So this is going to frame what our research is going to look like. What is the research question? So what's the population, intervention, comparison, outcome? Moving on to study design, the key here is how do we balance co-development of the best possible methodology to answer the research question? And we need to balance the robustness with feasibility. And that is somewhere where we need to learn from each other. I think universities can bring a lot of methodological expertise and robustness, but sometimes, you talk to academics and they'll say, well, here's a really great research plan, but it'll take us 5 years and £5 million to deliver this project. And actually, the budget you've got is £10,000 and you've got 6 weeks before you need to get an answer to inform your commissioning or to respond to a partner's question, etc. So I think there's something about how we learn to work together to produce good quality, but practical, pragmatic research that addresses the community's needs. That includes how we select patient-centered outcome measures, and there's lots of work, particularly in Birmingham, around patient-reported outcome measures. So really worth sort of thinking about involving those teams, but also thinking about other niche, if you like, areas. So there's something around process evaluation. How are we going to measure what our research is doing, why the research does or doesn't work? So some kind of process evaluation can be useful for some things, interventional studies particularly, health economics, carbon modeling. So looking at all these different things and bringing the right expertise in. And then thinking about using the university's wider networks, can we look at opportunities to collaborate with other local authorities? That could be, with Birmingham or Dudley locally, or it could be with other partners across the country, other councils. Maybe working with a rural coastal authority might be quite important to get contrasting perspectives and compare and contrast and see what we can learn from that. Study delivery. So university, very good at governance. So data governance, ethics, insurance, sponsorship, all specific to research. I think university has a role in supporting that. And then the research projects we undertake acting as catalysts that can actually build capacity. That could be by training people in the community and in the council to do research, setting up processes like ethics and insurance and sponsorship, and developing research leaders. Really important that through this process we're developing that leadership capacity as well. Thinking about how we improve data sharing and thinking about, should the study delivery have a participatory element to it? So how do we actually involve communities directly in the research activity itself? So analysis, really important things we can learn around improving the robustness of our analyses through pre-planned analyses, using reporting toolkits and so on. Making sure we bring in the right methodological support. As I've already said, it's not an academic you need somebody who's an expert in that particular area. What is the role of reflexivity in that? Probably something more for qualitative research, but we're thinking about. Co-development. Yeah, so this is the idea that actually once we've done our analysis, we've got our data, actually having workshops where we bring together all those different partners we've already talked about to interpret the data and to think about, well, how does this actually shift our understanding of the issue? What are the actionable insights for what we need to do next to improve patient and community outcomes? Planning through how do we go from a rapid analysis to dissemination and impact. And there's a whole range of different outputs there, academic outputs, policy outputs, public-facing outputs, making sure that we're looking at all these different ways to achieve, what we call knowledge mobilization, translating that evidence that we've generated into practice change. And I think, finally, just to end on universities again, I think we do have a role as neutral conveners. We're in the community, but we're outside of the health system and the social care system. And so we can be neutral conveners, a neutral space where people come together. We can support capacity building. And I think, the most obvious thing is we can provide methodological expertise. So hopefully that is roughly finishing on time to allow a bit of discussion.
Brilliant. Thanks, Dimitri. Yeah, finishing right on time. Got at least 5 minutes for discussion there. So I think Louise, who leads our Sandwell Consortium, has just put a comment in the chat around supporting the idea of a shift from research on to research with, and I welcome the efforts to make that shift in Sandwell through the HDRC and also through the NHS Trust's research team. Thank you, Louise. Did anyone have any questions specifically for Dimitri on that presentation? Okay, whilst we wait, I've just got one of my own. Dimitri, I know you've supported, I think, a number of HDRCs across the West Midlands with getting set up, and one component of that is sort of building the capacity for community researchers. I wonder if you were able to speak to that and with an example from one of the areas that you've worked with.
Yeah, so I was involved with Coventry as well, so HDRC. I think where the complexity, I think, is the practicality of moving from, it's easy to say we should work with communities and engage with communities, work with voluntary sector, but what are the practicalities of that? And I think some of those on the call will be familiar with some of the challenges. So, it's best practice to offer payment to public contributors to research, but sometimes the challenge comes up that some of the people who it's really important to engage, actually paying them um, monetary payment is actually quite difficult because of sort of benefit rules and things. So how do we kind of make sure that people are compensated for their time in a way that doesn't compromise their, um, the terms and conditions of the money they're receiving? How do we work with voluntary sector organizations in a way that compensates them fairly for their time and their expertise in a timely way, but fits into the framework of governance that local authorities and universities have to work within? So I think these are all surmountable challenges, but what it requires us to do is to be quite honest and to tackle those challenges head on rather than sort of trying to pretend that it's all very easy. I think it can be quite hard, but it can be fixed, and also we need to learn from people who've done it before. We don't need to reinvent the wheel every single time. I think that's something that people get quite frustrated by. So how do we kind of do that? So
Yep. No, thanks. I think you've touched upon some of the challenges that our Director of Public Health brought up at the beginning around a lot of talk around doing the right thing, but we need to get better at doing the right thing in terms of working with communities, and some of those challenges have been reflected on as well by our different speakers and those in the audience. Lena, did you want to come in with a question?
Yeah, I just wanted to pick up on the point about reflexivity, Dimitri. I thought you made a really good point about reflexivity in research and how that's typically more applied to a qualitative context. But I do think where local authorities and community stakeholders are involved in research and involved in shaping research priorities, I think there's something to be said for all of us, perhaps taking that step back and sort of considering where our own perspectives influence what we will, where we will be coming from, what we will recommend as priorities, and where we think we should be focusing on. Because I think really, I would probably challenge the idea that quantitative research is necessary. It's always seen as objective, isn't it? But actually, if you look at it, no research is ever fully objective, because someone is setting the research questions, someone is determining the outcomes, and even when we co-produce that, I don't know, I just wondered if you've got any thoughts on perhaps is this something we could build into the process, whether it's quantitative or qualitative research?
yeah, I think that's a really interesting point. In the global health literature, which is obviously quite different to what we're talking about, there is this concept of what they call the foreign gaze. So the idea that as maybe somebody from the UK working on a project in somewhere in the global south, you will bring with you a set of assumptions and kind of and that's not, it is because we all come from a particular context. We've all been brought up in a particular culture and in a particular society, and that means that we perhaps have assumptions about how societies work and values that perhaps don't translate across all settings. Now, where I'm kind of getting at is probably there people would say that can apply to quantitative analyses as well. What variables do you choose to collect because you think they're important variables to collect? Well, you might be missing important things because actually you just don't know, and you're making assumptions about what's important. So perhaps if we bring this back to the kind of local authority setting, it's also true that we probably sometimes come from a particular professional background where, you know, if you're a public health practitioner, if you're an environmental health practitioner, if you're a social worker, each of us comes from a different professional worldview where different things will be important, because that's kind of what we've been trained and that's the focus of our work. And but equally we might, and so each of us will have something different, and it's important that we kind of bring all those perspectives together to actually make sure we're not missing anything. But most important is obviously that all of us might be missing what's important to the community, because actually we're working within a particular kind of structure where you know, what's important to us is balancing the budget and, you know, making sure that we're delivering on certain statutory requirements. But actually, maybe what's important to the community is something completely different. So, yeah, so I think that reflexivity approach, as you said, I think it's kind of reflected in the co-prioritization. But you're right that it probably needs to run all the way through to then how do we actually even interpret the data, you know, bearing in mind that the way that I interpret the data might be different to how somebody from a different background interprets it. And therefore, rather than statistician does analysis, you know, somebody writes up paper, that needs to be a much more interactive process.
Thank you. Those are really good points. Thank you.
Thanks, Dimitri. So I can see that's generated some discussion in the chat and maybe one or two questions, but instead of taking those now, I'm just going to ask Dimitri if you could either respond in the chat or we'll pick those up when it comes to the question and answer part of Lena's presentation. So next up is Dr. Lena Martino. She is the director for our HCRC, looking at you right now, and she's going to talk to us today about insights from the HCRC in Sandwell and using research and evidence in local authorities. So please go ahead, Lena.
Thanks, Anna. And I'm fully aware that I have the slot which comes between everybody and their lunch. So I'll try to keep this a bit interactive. Next slide, please. So before I make a start, bearing in mind what you've heard today and some of the ideas you came here with today, when somebody says research, what do you think of? And just feel free to drop something in the chat or just shout something out. Oh, someone said scary. Inquiry. Reports, knowledge generation. Yeah, great. Understanding something new, looking for new information, new and exciting, exploration, university, findings, insight, data, typically academic. Academic again, so there's a theme coming here, sort of academic. There's something about labs, so there's something about a controlled environment, there's something about it being an academic process. Power hierarchies is a really interesting one, but there's also a big theme there around exploring, around finding new information, finding out things that are, you know, novel and innovative. Right, so I've just realised I'm trying to change the slides. Sorry, next slide, please. So I'm going to start with a little bit of background, and if we could just go to the next one, please. Because when we start thinking about research and how it happens in local authorities and how we use it, I think it's helpful just to take a step back and think about our recent history. So Frances will have alluded to some of this in her presentation, but public health functions were previously based in local government until the early 70s, then moved into the NHS, which is where it stayed until quite recently. And evidence-based practice became a core principle of how we do public health, as we heard from Frances earlier. And there was a very strong emphasis on the quality of studies and the hierarchy of evidence, which I'm sure many of you are familiar with. And understandably, a lot of health research tended to focus on healthcare systems and interventions. And to a point that's still very much reflected in research funding. So the majority of research funding for public health still goes to universities and the NHS. Now, the Health and Social Care Act 2012 moved public health back into local authorities, and it was actually around then I started my specialty training in public health. So as I said before, until that point I was an academic working in health services research, and desperate for my research to have meaning and applicability in terms of local practice. So when I arrived in my first placement at Coventry City Council, people had just gone through really big shift. There was a bit of uncertainty around how public health would operate in this new political environment, and specifically how we'd be able to continue that culture of evidence-based decision making. So personally, I've never known any different but public health being in local authorities, because up until that point, I was very much on the academic side. I don't like using the term side, but you know what I mean. But at the same time, there were some golden opportunities. So we were ideally placed to influence the wider determinants of health. So those conditions other than healthcare services that impact upon our health and well-being. So these are things like housing, education, employment, transport, the environment, all things that councils have an influence on. And we're finding that's now reflected in new funding and support opportunities that are available for local authorities, and that includes HDRCs. Next slide, please. So the NIHR Research Support Service Specialist Centre for Public Health, that's a bit of a mouthful, did a project fairly recently on how we define research in a local authority context. And we've spoken a bit about different kinds of research throughout this morning, and we've talked a lot about sort of academic research and working with academic partners. Now, the definition that the RSS came up with was local authority research supports decision making about practice, policies and interventions at a local, regional or national level, and or it helps us to understand how people are impacted by the context in which they live, work and go about their daily lives. So that's quite a broad definition, isn't it? It's I mean, I don't know, I mean, to some extent it fits the some of the things that were in the chat earlier, but some of it perhaps isn't quite covered there, but we'll come to that in a moment. Thinking about this first part, can anyone think of examples of where they might do this in local authority and how? So what are some of the activities you might do that support your decision making about practice and policy? So yeah, consultations, absolutely, that's a really big one. We do consultations with our communities. Just have another look. Health needs assessments, yeah. Yeah, what other areas doing? Yeah, absolutely. Benchmarking, comparisons, councillor briefings. Yeah, so there's lots of things that we might do, where we are using evidence and research. Now, typically, definitions of research tended to exclude activities like health needs assessment, research, evaluation and audit and consultation. It typically tended to exclude those things, and it tended to focus very much on research as the purer form. But this new definition gives you scope to take that into account. Next slide, please. And there's another part of that definition which adds context to it. So research uses structured, organised and reproducible methods to produce new information or knowledge. Remember, that was a really big theme that came up, which may include testing an idea, a theory or a new intervention. So thinking about this, you might pilot an intervention, evaluate it, see how it works, and or provide a new interpretation of existing information. And this can include routinely collected data being used for a new purpose, as well as publicly available data. And thinking about it, a needs assessment is an example of this. We might use several of these methods in developing a needs assessment. So we may use routinely available data that's publicly available to build a picture of need in our community. We may use consultation to discuss with our residents what they see as the issues and to bring out some of the whys. So we've already got some mixed methods in there. And we may also then be using evaluation of existing services to see, well, what's worked well so far. Next slide, please. So one of the ways that we are looking at, so one of the challenges obviously is that, yes, you know, there's a lot of existing research activity that happens in councils when you consider this broader definition. One of the challenges is in that sort of robustness. And when we talk about sort of systematic and reproducible, I mean, Francis, I think, made the really good point that sometimes it's less about that sort of, you know, wide generalizability, and sometimes we want to know what works locally and why. But actually, a lot of what we find out about our local population is transferable to similar populations. So, for example, we do quite a lot of work with diverse communities in Sandwell, where we look at some of the things that help to make our consultations more inclusive or our services more inclusive. Some of those findings are going to be generalizable to other areas. But one of the big challenges we have in local government is, first of all, there isn't really that broad culture around using research and evidence that we've been used to in public health, or at least historically, and also that there isn't, where it does take place, sometimes there isn't that robustness and rigor to make sure that we are minimizing bias. So I'm going to talk to you briefly about our HDRC because you've heard a few references to it. Quick show of hands, who has heard of the HDRC before they came here today? Could just use the, you know, the hand function. You can see. I think a lot of people here will already know what a HDRC is, which is great because it means I don't have to explain it in detail. Brilliant. Right, next slide, please. So we have a health determinants research collaboration, which is exactly what it says on the tin. It's a research collaboration looking at the wider determinants of health. We've called ours Better Research for Better Health because we think that HDRC tends to put people off. Many people thought initially that we were the tax office, and it was quite challenging engaging with people. So these are basically, there are 30 HDRCs across the country. And the aim is to enable local authorities to be more research active. It's £5 million of funding over 5 years from the National Institute for Health Research's Public Health Research Programme. And even though it is under the Public Health Research Programme and it sits within a public health team, the emphasis is very much on that whole sort of cross-sector working. You know, it's very much about all of those areas that the council has influence on. And the idea of the HDRC is that it will support evidence-informed decision-making to improve wider determinants of health, so the conditions where people are born, live, grow, work and age. They are place-based partnerships that involve the local authority, so they are local authority-led, but they also involve higher education institutions, voluntary and community sector organisations, NHS and wider health partners. Now, our main collaboration co-applicants are the University of Birmingham, SCVO and Sandwell Consortium, but we also work with a much wider range of partners and stakeholders, including the University of Wolverhampton, NHS, OHID, UKHSA, Keele University and others. Next slide, please. So Anna mentioned that we actually have an embedded researcher with us, Jane, who's organised the this conference today with our colleague Kira. So Jane joined us initially back in, I have to really think about this because I have absolutely no concept of time. I think it was 2022 as a first embedded researcher working on the evaluation of our COVID-19 vaccination leaders programme. And this was one of our first steps towards really trying to bring research more into our sort of local authority context. We have a very strong and very competent research and intelligence team, but I think it's fair to say that most of their activity focuses very much on the intelligence aspect and using local data rather than on the sort of research and evidence-based practice aspect. And there was an independent NIHR-funded needs analysis carried out in 2021, which found that the key barriers to us engaging in research was basically finances, budgets and workforce constraints. So Francis talked quite a lot about the barriers to undertaking research in this context, and those are obviously some of the key things that came out. And then it wasn't always seen as a priority for the council. So there wasn't really a culture of using research and intelligence. So there was very much that culture within the Public Health Directorate, but it was less widespread across the wider council. But high value was placed on local evaluation. So there was a lot of importance placed on, is it working for Sandwell? And the barriers that we found were in line with the wider literature. So this was the needs analysis was carried out by the University of Birmingham. And they found that the barriers were very much in line with wider literature on barriers in local authority generally. Oh yes, and Anna has just handed over chairing to Elaine. So I just want to very quickly say thank you, Anna. You know, we really appreciate you chairing today. Okay, so we also, in 2023, there was the Public Health Research Innovation and Engagement Study, the PRIDE study, which was carried out across the Public Health Directorate. And it was to see what were people's experiences of research, what was their confidence in carrying out research, and, you know, did they see the value of it in their roles, and were they able to do research in their roles? And what we found was that, unsurprisingly, public health practitioners do recognise the value of research. They require greater support to be able to do research and to embed it into practice. And that comes from both internal structures and external partnerships. And we had a strong existing infrastructure. So when we put together our HDRC bid, we'd initially made a bid in 2021, but we were unsuccessful at the first stage of the bid. And so we built on this to then develop a new bid and to build on that. There was a very strong existing infrastructure. So we already had good partnerships with the university and with our voluntary sector. We've got strong community assets in Sandwell, and also the council was very much focusing on this data-driven approach and also more collaborative working across directorates with the one council, one team approach. So the you know, we had the right kind of environment to have a HDRC, as well as having high need, because obviously Sandwell is one of the most deprived areas in the country. Deprivation is widespread and systemic. And you know, there is quite a lot of work to be done in those areas. So next slide, please. So just to summarise our work streams, I won't say too much about these because I'd really like to focus on the learning from the HDRC to date. We have 4 parallel work streams. 2 of them are very internally facing and 2 are very externally facing. So our internally facing work streams focus on building our research capacity and infrastructure, and that's through training and upskilling our staff, sort of looking at our data infrastructure for sharing information and evaluating interventions, and also looking at our research structures and processes and the governance around those. And then there's something about embedding research culture and evidence-informed practice, and that work stream is about translating that research evidence into practice and increasing the use of evidence in decision making across the council. And externally, we are strengthening our systems and partnerships with academic collaborators and also wider system partnerships. And we're also increasing community participation through increasing the existing structures that we have for public participation and involvement. So next slide, please. So for the last few minutes, I'd like to focus on what we've learned from this process. And so next slide, please. So I've just realised that I have put section breaks in, which don't work so well when someone else is doing your slides for you. So we are in the process of analysing data from our baseline assessment, which is where we are now. So this was carried out in 3 phases. So there was, for the first 2 phases, there was a study of the current research culture with the University of Birmingham Institute for Local Government Studies. And this was around assessing the role and perceptions of research across the council among our senior leaders and managers. So the first phase was looking at strategic leadership teams. So this was the chief exec and exec directors. So there were 7 participants. And the next phase was interviews and focus groups with our wider leadership team, which was our assistant directors and service managers. Then we had a wider staff survey, which was a research skills and knowledge survey with our council staff across all directorates. We received responses from all of directorates, and I think 617 responses in total, which was actually more than double that received by any other HDRC for comparable activity. So we were, although it was just 15% of our workforce, we thought this was actually very good uptake. This assessed the existing skills, confidence and capacity for research and translation of findings into practice. We're using it to identify training and development needs to inform our staff training offer, and the team used a range of innovative data collection methods to maximise uptake, including going into team meetings, and they also had their Samosa Survey Wednesdays, which became quite famous among the council, among council teams, where basically they would give people samosas in exchange for completing surveys. I'm not sure how public health that approach is, given that samosas are fried, but it worked. Next slide, please. So just very briefly to summarise the findings. So in terms of the current use and the context, there seemed to be a split between, how people viewed evidence versus research. So that was there was a split between people differentiating local intelligence to support policy or operational decisions, whereas the broader insights to inform strategic decision making. There was the high quality data was valued both internally and externally, and there was generally pockets of good practice. So there was frequent good use of data and intelligence and research, but it was a bit fragmented and it wasn't very consistent. Barriers, as we know, included limited capacity and resources, lack of coordination across departments, and the short-term nature of political cycles, which means that, obviously we know that research can take time, and sometimes this wasn't in line with political cycles. Facilitators include, there's definitely been a shift towards critical reflection in policy making, and there is an openness to challenge current practice. So across the council, senior leaders are very keen and very supportive to make these changes. We have a number of new managers who've got relevant experience, and the requirements for evidence in cabinet proposals have actually been strengthened in recent years, for example, through equality impact assessments and a new process around getting evidence into those. And for future developments, some of the things that were highlighted were sort of building a cohesive research culture where evidence is really part of policy and operational decisions, having a more coordinated approach to research and managing data, including through a corporate data strategy, sort of building capacity and resources, including through having dedicated research posts, and also resources to support people with using evidence, for example, user-friendly summaries of research and what works, and also enhancing our community engagement, particularly in expanding how we use qualitative research and really building in the quality of that research. Next slide, please. So tier 2, we found strong alignment with the tier 1. There was a general recognition that using evidence and research for decision making is important. Both groups identified a need for evidence to be more systematic and more coordinated, but the perspectives were quite different. So SLT, so senior leaders tended, so the Chief exec and directors tend to see it very much from a strategic or corporate perspective, as you'd expect, whereas service managers, consultants, and assistant directors tended to view it very much in terms of delivering their own services and how this could be improved. And the latter group highlighted the more practical aspects, such as the mechanisms by which it takes place and capacity requirements. And they sort of cited things like staff skills, communication channels, and data systems. And what this suggests is there is a shared vision across the council for evidence-informed practice that operates at very different levels. And we need to understand how these levels link together so that we can embed a research culture. And next slide, please. So tier 3, we're still in the process of analysing results, but key learning from the process is that staff did tend to see research as that purist form rather than the broader definition, such as needs assessments and evaluations. They were most often carrying out research in their day-to-day work, but didn't see it as research. And this included things like desktop research, data analysis. They didn't really see some of it as research activity. And during the discussion, the team had to sort of extract where staff were using research in their roles. And managers found it much easier to identify where research was being utilised rather than their teams. So there's something there that we need to think about how we communicate this more widely. Next slide, please. So I'm just going to finish on some very quick additional reflections. And next slide, please. So first of all, on team and capacity building. So we started the HDRC in 2024. And it was January 2024. And the first 6 to 9 months were focused on building the team. And we didn't know what kind of response we were going to get because HDRCs were a relatively new concept. There was a wave before us, including Coventry, who we managed to learn a lot from. But we found that through our application process, through our recruitment processes, there were lots of people that had transferable skills and experience. And there was a big appetite for roles that are relevant to this kind of work. And it was really important to consider the function of the role when we were developing the person specs. So what could we learn on the job? And we also felt that diversity of experience and perspectives was an asset. And we've certainly found that in building our team. Next slide, please. In terms of working with universities and researchers, we've talked already about that culture exchange rather than a one-way culture change, and that university researchers are really keen to see their work translated to practice. And I think one of the key things to highlight from here is that councils and universities have very different priorities and processes and support for managing risk. And that can really create barriers to formal collaboration. And I'll tell you now that the collaboration agreement that we are developing between our co-applicant or partners is the thing that keeps me awake right now. I think there was a reference made to what keeps you awake. Well, that's mine right now. Next slide, please. I'm just going to go very quickly through this one. And in terms of working with communities in the voluntary sector, we've already highlighted the limited resources and capacity being a barrier to being involved. So we've already recognised that we need to adequately reimburse time for public representatives. We know that co-production is the gold standard for community participation, but we also have to balance it with timeliness of outputs. So that's something to think about. And also when we're developing our formal agreements, it's just making sure that we minimise any financial risk to our VCSE collaborators because they don't have the same access to legal support and insurance that we have as bigger organisations like councils and universities. I think that's the end of it. Thank you for listening. Does anyone have any questions in the final moment?